day and welcome to Epstein, Becker, Green's, and EBG Advisors webinar, The Impact of the ACA on Population Health Management. We are pleased to have two fantastic speakers today, Becker Green, Lynn Snyder, who is a senior member of the HGLF practice, and Gary Cohen, owner and principal of Gary Cohen. The importance of today's webinar is being recorded, and the participant phone lines will be placed on questions throughout the program by using the Q&A feature provided by WebEx. And at the end of the program, with time permitting, the speakers will address your questions. Submit questions directly to the presenters following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business following Epstein, Becker, Green will communicate with you and access to PowerPoint materials. It will include a survey so we can get your feedback to future programming. At this time, I'd like to turn over the webinar to Lynn Snyder.
This is Lynn Snyder. I know we're having some audio difficulties. We're just trying to the audio.
So basically, email Gary.
This is Lynn Snyder from Epstein, Becker, and Green. Good afternoon, everyone. Hopefully the audio will be better. I've been here at Epstein, Becker now. Just after Labor Day was my 35th anniversary, believe it or not, doing Medicare, Medicaid, and managed care issues. In addition to my work at the firm, I'm one of the strategic advisors in our consulting arm. It's called EBG Advisors. And EBG Advisors recruits all different types of healthcare professionals to provide consulting services to assist us in some of our projects, because very often our projects include both legal and consulting. And we appreciate this series and having Gary Cohen on as our speaker today, because Gary is one of our EBG advisors. So at this point, I'd like to turn it over to Gary for him to introduce himself, and then I'll give an overview of what the presentation will be about. So Gary, if you could introduce yourself, please.
Thanks, Lynn, and good morning to everyone from out here in California. Good afternoon to those of you on the East Coast. As I imagine most of you know, I was director of CSIO, the Center for Consumer Information and Insurance Oversight in CMS up until the end of March of this year, the end of open enrollment. I came to that work because I had previously been a state regulator. I was general counsel of the California Insurance Department. And my boss there, the insurance commissioner, John Garamendi, was elected to Congress in 2009, and I came out to Washington to work with him and served as his chief of staff, and had the real, sort of privilege and excitement of sitting in the gallery at the House of Representatives when the Affordable Care Act passed. And a few months later, found myself over at HHS, joining what was then a very small group of people that was charged with implementing that law. Initially, my responsibility, consistent with what I had been doing before, was to work with states, insurance regulators, and with the NAIC on making sure that the initial market reforms of the ACA were complied with. And then over time, eventually, as I said, became the director of CSIO, and left at the end of March, and now I'm back home in California, and I have my own law and consulting practice, and I'm very pleased to be working with Epstein, Becker, and Green advisors.
Thank you, Gary. Let's go on to the presentation overview. Just so everyone knows, we're very excited about our Thought Leaders in Population Health series, and we thought with the upcoming open enrollment November 15, maybe we should take a little snapshot of how much progress there's been under the federal and state governments in expanding healthcare coverage and bending the healthcare cost curve. We're going to be talking about the specific insurance reforms to the individual and small group markets, which were the heart and soul of Title I of the Affordable Care Act, as well as the emerging trends such as the role of accountable care organizations, patient accessibility issues, and just the drive towards integrated population health solutions. We're going to talk about, what the goals were, whether we're getting to a point on implementation of achieving those goals. So Gary, let's just take that step back and make sure everybody knows what were the goals of the Affordable Care Act, especially Title I. Thanks. Gary? Are you on mute? We're having audio challenges. Please stand by. We're just trying to fix one more audio thing. It's one of those days. Thanks.
Hello?
Gary, are you back?
The chat people say they can hear me.
Okay, good. So that's great. If you
want to
take us through the goals of the Affordable Care Act.
That's what I'll do. So I thought it would be helpful to step back and take a look in assessing the impact on population health management. What was the ACA trying to do? So broadly speaking, improve health by increasing access to care and reducing costs. So one aspect of that were reforms to the healthcare insurance market. Some of those reforms were intended to increase the number of insured, for example, doing away with prior condition exclusions and requiring that kids up to age 26 be insured on their parents' policies. Some were intended to make sure that coverage would be there when it was needed. For example, the Essential Health Benefits Package, the elimination of annual and lifetime limits on coverage, and some were intended to make sure that the insurance would provide good value, for example, medical loss ratio and rate review. And then, of course, the exchanges and Medicaid expansion were directly intended to increase the number of people with coverage by providing subsidies for purchases of private policies through the exchanges and by expanding Medicaid. So we can go to the next slide. Thank you. So in terms of increasing the value of insurance coverage, I'm sure people are familiar with the medical loss ratio, the idea being that 80 cents of every premium dollar in the individual and small group markets should be spent on health care and activities to improve health quality, and 85 cents in the large group market. Rate review calling out unreasonable increases, which as interpreted by the regulations that we did, really meant increases above 10% that would result in a loss ratio that was below the required threshold. And then in addition, primarily through the exchanges, we'll talk about some more, to increase competition. And then there are parts of the Affordable Care Act that were directly intended to attack the cost of care and to bend the cost curve. And I should add to this slide the requirement that preventive services be provided to people without cost sharing. So overall, the goal being get people in coverage, reduce emergency room visits, increase access to primary care, increase access to preventive services, all with the goal of improving health and reducing costs, and then promoting some of these new ways of doing coordinated care and integrated care, such as the patient-centered medical home and ACOs directly in the Medicare program, which we'll talk about a little bit later.
So this coming November 15th is the beginning of the second open enrollment period. As many of you should know, it took several years of ramp up in order to get the first year off and running. Gary, let's do a report card. How are we doing now with the market reform?
So the market reforms went into place, and really, notwithstanding a lot of the controversy over the law, without a lot of controversy or difficulty in terms of implementation. Almost all the states continue to regulate their insurance markets and enforce the provisions of the Affordable Care Act that apply to the carriers in their state. There are 5 states which chose not to enforce the reforms that came into effect in 2014, and for those states, CMS is enforcing those directly, which means that carriers are submitting policy forms directly to the federal government, and they're being reviewed and determined that they are in compliance, which is a very sort of different and new role for the federal government. But compliance level is high. There haven't been a lot of instances of complaints of the basic provisions of the law not being complied with. However, due to the decision that was made in November of last year to allow some non-compliant plans to continue to be renewed up through into 2016, there are a substantial number of people who remain on, in previous pre-ACA plans that are not compliant with all of the market reforms, which was not, originally the intent, but came about as a result of the policy that was announced last November. And in terms of enrollment, obviously everyone knows all too well the problems that existed with the beginning of the rollout of healthcare.gov. Some of the states has also had significant issues. Some did better. But at least on the federally facilitated healthcare.gov side, a tremendous amount of work was done, and ultimately the goal that had been set by the Congressional Budget Office of 7 million enrolled through the marketplaces in the first year was met and exceeded. 8 million ended up enrolling. CMS or HHS just recently announced that 7.3 million of those have actually paid their premium and are in coverage. And at least one estimate of the Kaiser Family Foundation is that 4.6 million of those were previously uninsured. And there have been a number of articles and studies and pieces written about what the impact of this has been. Gallup has been tracking this for a while and has reported recently that the percentage of uninsured adults in America fell from 18% in the third quarter of 2013, just before open enrollment, to 13.4% in April of 2014. In terms of Medicaid expansion, the latest report that came out that said that as of July, more than 67 million were enrolled in Medicaid and CHIP, which was an increase of about 8 million over October 2013. Obviously, not all of that is due to expansion. There would have been a growth in Medicaid, even without expansion. But these numbers are changing all the time as enrollment in Medicaid is year-round. And in terms of the scorecard, obviously, enrollment would be significantly higher if all states had expanded, but because of the Supreme Court's decision, approximately half the states thus far have chosen not to expand.
So when Gary and I were putting together the PowerPoint, one of the things we talked about were what were the three main things where population health management is being driven by ACA reforms. What would be the top three things? And we came up with medical loss ratio, rate review, and increased competition. So Gary, take us through those three big ACA reforms and how they're making a tremendous impact on population health management.
So in terms of, the increasing value, the medical loss ratio, as I said, the purpose is to make sure that a minimum percentage of premium is spent on healthcare and activities to improve quality. Prior to the ACA, in the large group market, by and large, those thresholds were being met, but there were in a number of places where loss ratios were down in the 50s and 60s. And so what we saw was initially a very large, over $1 billion in rebates for the 2011 plan year were paid out because plans did not meet the threshold, and that number has significantly decreased over the next 2 years, so that for the plan year 2013 was only $330 million. And that is really to be expected and was really the point, which is the point is not to pay rebates, but the point is to make sure that more premium dollars are being spent on healthcare and quality improving activities, and clearly that is happening, and plans are coming up to the threshold. In terms of rate review, it really works together in many ways with the MLR, because as I said, one of the purposes of rate review is to make sure that rate increases are not going into effect that will result in higher premiums, but then the MLR threshold not being met, and then the plan has to turn around and end up paying back in rebates. So the program provided grants to states to improve their rate review programs. Some additional states adopted prior approval laws, and 34 states have prior approval in at least some of their markets. In the federal program, there is no prior approval. It's strictly calling out as unreasonable increases that would result in a loss ratio below the threshold, or that are in some other way not justified by the information that the carrier had put forth. And there has been some evidence, and HHS put out an additional report recently to show that there has been an impact in terms of the difference between the rate requested by an issuer and the rate that eventually actually went into effect. And then in terms of increasing competition, as I'm sure everyone on this call knows, the health insurance markets historically have been highly concentrated. In 2010, before the ACA went into effect, one insurer had at least half the individual market share in 30 states and the District of Columbia. The law seeks to increase competition in a few different ways. Sort of the most obvious is, well, we're going to bring all these new customers in, both because of the individual mandate and because we're going to provide subsidies to help them pay for the cost of premiums, and that opportunity for all these new customers should spur more entrance into the market, more competition for that business. And then directly, the ACA provides for a program of co-ops, consumer-owned and operated health plans that receive favorable federal loans to get started and to come into the market, in recognition of the fact that there are very high barriers to entry in this marketplace. So 23 co-ops were funded. Initially, the program was intended to provide for a co-op in every state, but the funding was cut in the fiscal cliff deal, so no new co-ops can be funded. However, there was additional money available to allow existing co-ops to expand into new states, and that is happening in 2015. So there will be some co-ops new co-ops coming into some states, but they're tied to existing ones. It's not a brand new entity. And co-ops have to be licensed by the state and go through all the regular process that any new insurance company would have to go through. They reported enrolling 400,000 people in the initial open enrollment in 2014. There's a lot of variation in terms of how successful they were. The factors primarily being where they were priced relative to the other entrants in the market. Some were priced fairly low and achieved a high market share. Others were priced relatively high and achieved little. And then there were some co-ops and some of the state-based marketplaces that had problems with their systems and were handicapped to some extent because of that. I've called out just two of the real success stories: Maine, which achieved 83% of the marketplace enrollment, and Kentucky, which achieved 60% of the marketplace enrollment. It's also important to note that co-ops, as part of their mission, and when you talk to the executive directors of the co-op companies, or the CEOs of the co-op companies, they very much see as part of their mission to promote the kind of coordinated care and delivery system reform mechanisms that we'll talk about in a few minutes in order to improve quality and reduce costs to their members.
So Gary, cost shifting isn't what it used to be, and the ability, based on the rate reviews, et cetera, to just pass along the costs either from the insurer, the employer, and then down to the consumer. So are we finally going to bend the cost curve? Is that what's happening? I know that there are different factors going on. So let's talk about bending the cost curve and whether the ACA gets credit for some of that.
That's great, Lynn. Thank you. So what we know is that real per capita health spending has grown at a much lower rate than has been true historically. So as it says here, the average annual rate of 1.1% from 2010 to 2012 compared to a 4.6% long-term average. And the CMS Office of the Actuary recently came out with some information saying that they expected that low growth also continued into 2013, although all the numbers are not in on that. Healthcare inflation has been also very low at around 1%, much lower than has been the case. And healthcare premiums have also been increasing at lower than historic trends. And in some cases, what we're seeing from 2014 to 2015 is our premiums going down. And there's a lot of debate as to how much of that is due to the ACA, how much of that is due to real structural changes that are happening in the health insurance market, how much of that is due to the fact that there was a recession and healthcare usage tends to decline during bad economic times. You can go online and you can find studies that point in all different directions on that question. Some would say, really it was mostly due to the recession. Others would say, no, there's really good evidence that some of this is real and will persist. I think, as with so much of what's happening now, it's very difficult to make judgments based on such a short period of time that we've had. I mean, full implementation hasn't been in place, even for a year yet. I would say the jury is still out as to whether those trends of lower cost growth are going to continue, or whether they were largely due to the economic downturn, and if the economy continues to pick up, they'll go away. I think it's certainly true that there is a lot of activity in the market now, some spurred by the ACA and some just spurred by the market reality that is driving participants in the market to try to achieve cost savings. So I think go ahead.
I was going to say, you know, the interesting thing about bending the cost curve and what you're saying is that we've had lulls in the inflation before, and then people pick it up later as if there was pent-up demand. So I think you're right. It's less than a year, and we'll have to see what happens. Tell us about the challenges ahead.
So I just wanted to point out a few things as we look toward open enrollment starting in November that remain challenges and questions as to how well, you know, they will be dealt with. So one, and you know, this has gotten a fair amount of press, is that what happens when the information that people who are applying for coverage is different from the information that's received from the federal data sources with respect to citizenship, with respect to immigration status, and also with respect to income, too. And so CMS announced that as of August, there were still 210,000 cases that remained open, but that they had made a real significant progress in dealing with those. There were you know, 310,000 people who didn't respond to requests for additional information, so they got notices that if they didn't respond, their coverage was going to be terminated, and that happened, you know, to a significant number of people. And then the question being, you know, will the problem of backlogs and not being able to deal with these inconsistencies on a more current basis persist into 2015, or will improvements that CMS has made enable some of these determinations to be made, you know, more readily? And that remains to be seen. And then there's also been significant problems. This is to some degree on CMS side, to a significant degree on the state side, in changing their systems to comply with MAGI Medicaid determinations, which they had to do regardless of whether they expanded or not. Every state had to, you know, make changes in their systems and had to be able to exchange data with CMS. And there were problems, as I said, on both sides of that data transfer. And so a number of states have experienced significant delays in enrolling people in Medicaid. California said in May that they had a backlog of 900,000 pending applications. Kaiser Health News reported in June that in 15 states there were 1.7 million backlog. And CMS has begun to press some of the states that have not moved forward with changes to their system and have not come up with mitigation strategies that are adequate to deal with these issues. And then looking forward to open enrollment in 2015, for plan year 2015, CMS is going to give notices to people if data from the IRS shows that they may not be eligible for tax credits or cost-sharing reductions for 2015 based on their income. Other people, if they take no action, are going to get the same subsidy that they received in 2014. And then there would be a reconciliation at tax time if it turns out that that's not accurate. One issue that's come up that applies to this is that if the cost of the second lowest cost silver plan that's available goes down, which may happen in some places, then the amount of the subsidy will go down. And unless people come back into the system and go through the application process again, they won't know that the subsidy that they're receiving, which is the same as what they got in 2014, is actually higher than the subsidy to which they're entitled because of this decrease in the cost of the second lowest cost silver plan, which is what determines what the subsidy is. So they may be surprised come tax time, which won't be until April in 2016, that the actual amount of the subsidy that the tax credit that they receive is lower than what they had thought, and then that may be compounded to some degree by the fact that people are going to be re-enrolled in the same plan that they had in 2014 if they don't do anything, and if that plan is still available. And then there's a process that CMS has recently come out with what will happen if the existing plan is not available, where they'll be put, but they'll be put somewhere. And if the cost of that plan that they were in for 2014 goes up, but the premium, the subsidy goes down because some other plan becomes the second lowest cost silver and the amount of the subsidy goes down, then there could be an impact on people due to that as well. So I think we're going to turn now to the subject of what is happening due to the ACA and in the marketplace in terms of bending the cost curve. And so the direct effects that the law has in this area are primarily in public programs, especially in Medicare, and include reductions in excessive payments in the Medicare program, and also encouraging new payment models and payments based on outcomes, for example, penalties or bonuses for reduced hospital admissions. And then direct pilots for accountable care and bundled payment models. And recently there were results of what the Medicare ACO's experience has been. I think it's fair to say that the initial results have been mixed. Some achieved significant savings and received bonus payments as a result of those. Some did not. Initially, the Pioneer program, which is the most sort of aggressive of these pilots, had 32 plans participating in it. It's now down to 19, and there's some concern about that, in terms of how well it's working and what the long-term effect of that will be. And there recently have been some report on quality measures as well, and there too there's been some very good results, but in other cases didn't fare so well, and that's to be expected. It's not to be expected that all of these things are going to work perfectly and brilliantly, right away. And again, I think it's important that we continue to watch these programs over time and make an assessment of what their impact has been, not just looking at 1 year's experience. So the topic that has gotten probably the most attention, particularly over the last few months, it seems like every time I look in a newspaper, or certainly look in a trade publication or the like, there is a discussion of narrow networks. And the question of what the impact of narrow networks has been. So we know that narrow networks obviously are not new to the ACA, but also that the ACA has, in marketplace plans, narrow networks have been prevalent. And McKinsey reported that 70% of the lowest cost exchange plans were built on narrow networks in 2014, and also that it made a difference, that premiums were 13 to 17% lower than comparable plans with broader networks. And there's recently a very interesting study from the National Bureau of Economic Health based on some experience in Massachusetts that showed that when people were given an option to choose a narrow network plan, many did, because of the lower cost, and that there was a significant decline, not just in the cost of the premiums, but there was a significant decline in healthcare spending without a decrease in quality. That was the what was reported was in that study. But this has raised significant issues in terms of the relationship between cost and access and choice for consumers.
So one of the issues with narrow networks is who's regulating it, and that's one of my areas that I spend a lot of time on, because sometimes the states are not waiting for SOCIO to be the regulator of what is too narrow a network. Narrow networks, the concept goes back to even the federally qualified HMO days of how do you decide availability and accessibility. So knowing that the states are not waiting for SOCIO, and that one narrow network in one state is not the same as a narrow network in another state, we've asked Gary to take a deeper dive on this issue of narrow networks. Gary, tell us a little bit about the network adequacy and what's happening at the state level.
So you're absolutely right. Looking first at what the there are a variety of types of regulation that are available, whether it be from the federal government or from the states. A very typical standard is just a general standard, which is the one that CMS adopted initially. The network has to provide access to covered benefits without unreasonable delay. And then it's a question of, sort of what does that mean? On the one hand, then moving, in the other direction to very specific time and distance requirements where, there has to be a primary care physician within, X number of minutes or X miles from everyone who's enrolled in the plan. Typically, quality, from a pure network adequacy standpoint, quality is not a factor in determining whether the network is adequate or not. A provider is a provider is a provider. This is an area that I think it's fair to say states and the federal government have found difficult to enforce. It's generally going to be driven by complaints as opposed to some kind of, monitoring activity. So one issue that has arisen and is a very serious issue, and I think a real challenge for both industry and regulators, is the issue of transparency and the issue of choice. So McKinsey says more than 90% of people who chose plans in the marketplace actually had the choice of a plan with a broad network. There was a plan available to them that had a broad network. And for most consumers, they were choosing, that were choosing a plan. Price was the most important factor. So people were, looking for, a lower cost plan. The question being, though, do consumers know when they're choosing a plan what they're getting in terms of the network and who's in the network and whether it's narrow or whether it's broad, and what sort of access they're going to have. And it has been a real challenge for both for industry and for regulators to provide consumers with accurate, up-to-date provider directories so that people can know both who's in the network and just as importantly, who's taking new patients. Out here in California, Covered California had a goal of providing provider directories. They were not successful in doing that. They had it up for a while. It wasn't accurate enough. They had to take it down. And I think that there have been a number of issues that have come up, in a lot of places where it's just very difficult for consumers to know when they're making this choice about, access versus cost, just what that trade-off entails. So the response from regulators has been very broad. A lot of different possibilities have been under discussion. Not too many new laws have been enacted, but some have. And in Washington, as one example, the Insurance Department came out with new regulations on network adequacy that really cover the entire waterfront of all possible ways of regulating this issue. So they have general standards, that say that services have to be provided in a timely manner without unreasonable delay and unreasonable proximity. Hospitals have to have adequate capacity. There has to be an appropriate ratio of primary care providers to enrollees. But then they also have very specific requirements for how long it can take to get an appointment. They also have time and distance requirements for various services in terms of how many minutes it should have to take to get there. So they really have, kind of approach this by, every possible way of regulating networks they have adopted, including a number of provisions to increase transparency as well. So on the next slide, they require the provider directories be updated monthly. They specify the information that they have to have. The network plan has to be approved by the department, and there has to be a plan for what you're going to do to refer for out-of-network services if services are not available in-network. And the issuers have to make public the criteria that they use if they have a tiered network where cost sharing varies depending on who the provider is. They have to make public what the criteria were for assigning providers into the various tiers. So that's sort of one extreme, I would say, in terms of regulatory approach. Right now, the National Association of Insurance Commissioners is considering amendments to its network adequacy model law. It currently applies only to managed care plans and is general. It does not have specific time and distance requirements or that sort of thing. It's not clear at this point what they will end up adopting. I think their goal is by the end of the year to come out with a proposed regulation for the commissioners to consider. As Lynn said, there in the discussions, it's very clear that states vary a lot, and even within a particular state varies a lot in terms of what's appropriate in a highly populated urban environment versus what's appropriate in a rural environment. And what some state regulators will point out and say, well, we have a shortage of doctors that is not, is an issue that's separate and apart from what the insurance network might be. It may be difficult to achieve, what a regulator would consider adequate access to care, even if you included all of the providers in a particular area, because they just, there isn't a specialist in a particular field that is close enough to people who live in a rural area, for example. And then, obviously, whatever the NAIC does is a guide for states to consider, but it takes state action, either legislatively or in regulation, to actually make that apply in a particular state. SCIO has a network adequacy requirement for qualified health plans that are sold through the federally facilitated marketplace. It's general. For 2014, network adequacy review was left entirely to the states. For 2015, SCIO required plans to submit information on their networks and has said that it's going to be reviewing that information and identifying outliers. It's not clear exactly what it's going to do, but it has the ability to refuse to certify plans to be sold through the federally facilitated marketplace if the network is deemed to be inadequate. And it said that it's going to consider network adequacy review based on standards similar to what's used in Medicare Advantage, which does have time and distance requirements, but that would require further regulation and would not be able to be into effect until the 2016 plan year. It won't be in effect for 2015. And then NCQA has also weighed in on this issue and has included new requirements with respect to narrow and tiered networks for accreditation for 2015. Similar to one of the things that Washington State did, their plans are required to disclose their criteria. Why are certain hospitals or certain physicians included in the network and others not? And plans are required to monitor complaints and appeals and requests for out-of-network services so that they can report on those as well.
So we want to move on from narrow networks to bending the cost curve, but a deeper dive. We wanted Gary to spend some time on ACOs, particularly in the commercial market. The last few days we've read a lot about ACOs in the Medicaid market, but I think we wanted to spend some time on the commercial market and to look at some of the other innovative things on population health in the commercial side. So is the commercial market bending the cost curve, Gary?
So there's a lot of activity going on. You know, I think, as I said, I think spurred in part by, you know, changes that are being brought about in the marketplace, and in part by changes that are being brought about because of the ACA, and as you said, Lynn, just the recognition that it's not going to be possible any longer just to pass these increased costs of care year after year after year. And I think, in addition, you know, a general desire to promote, you know, what Don Berwick has called the triple aim of improving people's experience with the healthcare system, improving outcomes, and reducing costs. So, as an example, I thought I would talk a little bit about what Blue Shield of California has done. Blue Shield of California came early to the ACO experiment, let's call it. California is a little bit different from a lot of other states in lots of ways, but in one way that's relevant here is that managed care is still very highly prevalent in California, and in part that's due to the fact that one of the three major issuers, Kaiser Permanente, is a fully integrated system, and because of that, it has the ability to do a lot of the coordinated care and other types of activities that everyone feels are going to end up resulting in better quality and reducing costs. So the question then is, well, how, you know, if you don't have a fully integrated model, how can you try to achieve some of those same goals? So what Blue Shield of California did was they started in Sacramento with a hospital system, a provider practice group, and a set of enrollees who were California state government workers. And they brought the insurer, the hospital, and the doctors together to form this organization, and they established a global per member per month target for the cost of healthcare for the entire population. They didn't change whatever the underlying payment mechanism was. So if it was a fee-for-service, it stayed fee-for-service. If it was a capitated model, it stayed a capitated model. But they had a global target for what the cost of healthcare should be. And then they broke that down by the different categories of healthcare service, you know, inpatient, you know, hospital, physician visits, you know, et cetera, et cetera. And they said, we're going to share savings and risk. So it's both, if we do better than the target, we're going to share the savings, but if we fail to meet the target, we're all going to share the risk for the costs within each of those services. And they said, we're not going to have any shared savings unless we achieve certain quality goals. And so they formed this first commercial ACO with Dignity Health and Hill Physicians for CalPERS employees and an HMO product in Sacramento in 2010. And they adopted 5 strategies to try to achieve these savings. They tried to improve information exchange. They tried to coordinate processes such as discharge planning, eliminate unnecessary care, reduce variations in practices and resources, so promote best practices, and reduce pharmacy costs. And they said we're going to share the risk depending on each participant's ability to influence those costs. So it wasn't a third, a third, a third. It was, it varied depending on who really had more control over whether those targets were met. And the experience has been successful. Over time, CalPERS has saved $95 million in premiums. The partnerships shared $10.2 million in savings, and total hospital days and hospital readmissions have fallen both compared to prior year and to those in the same year who were not in the program. So Blue Shield has been expanding this idea. They now have 20 ACOs operating with 227,000 members across the state. Their experience has been that the average annual increase in the cost of health care has been 3% compared to 7% for non-ACO members. There have been reductions in hospital admissions, inpatient days, readmissions, and emergency room visits. And they are continuing to expand the program. For the first time, it will be offered through a marketplace product in 2015. And their goal is by 2018 that 50% of their members in the state will be in an ACO product. There remain significant questions, and if you look at the literature, you'll see that what generally has been written is ACOs are successful in reducing costs initially, but then still the unanswered question is, will those savings persist over time, or is there a question of some low-hanging fruit? You're able to achieve some efficiencies, but then over time those savings are going to, start to dwindle, and I think that remains to be seen. And again, I think we need to have more experience with these different models in order to determine what their long-term impact is going to be. So this brings us back to the question of what the appropriate response, both industry and from regulators is to some of these different models of managing population health. So obviously the ACO, as I described what Blue Shield was doing, is a narrow network. The question then becomes, are people going to be satisfied with their choice of provider and what's being done to reduce costs with what's being needed to provide adequate access? And adequate access doesn't just mean adequate based on whatever network adequacy standard might be applied, but adequate access means, are people complaining because they feel like they can't go to the doctor that they want to go to, or they can't go to the hospital that they want to go to. And that raises, again, the question of how can consumers be given, enough information to make informed choices, and do they appreciate that they're in an ACO? Do they appreciate what the benefits of being in an ACO are? Do they understand what the criteria are for who's included in the ACO and who isn't, and that there's a reason why a particular hospital, is in network, or a particular provider group is in network while another one isn't? And so I think, a significant challenge moving forward is to demonstrate, both for the regulatory community, but also for the community at large, that these decisions are being made with a goal of improving quality and reducing costs, and that those goals are actually being met, and that therefore people should, people can make then a choice. Is, no, I want to be able to go to whatever doctor I want to go to, or I want to be able to go to whatever hospital I want to go to, and I'm willing to pay more for that. Or, no, it's quite okay with me if I have limited choice, and actually I'd be okay driving a little bit further if I thought that the quality of care I was getting, the integration of care I was getting, the coordination of care I was getting meant that I was going to get better care and actually ultimately better outcomes and lower cost.
So thank you, Gary, for the presentation. We do have a couple of questions coming in that I want to go over. Before we go to the question and answer, I just wanted to mention Bloomberg BNA is about to publish this week, make available a portfolio. I co-authored it with my colleague Tanya Kramer here at Epstein, Becker & Green. It's all about the mostly about the state and federal regulatory climate for accountable care organizations and other provider risk-sharing arrangements. It was a portfolio written by one of my other Epstein Becker colleagues back in the 1990s when we had a lot of PHOs, and it needed a big refresh this many years later. When the Medicare ACO regs came out, and it requires the ACO entity to have its own tax ID number, it raises the whole issue because the ACOs don't necessarily have to be separate entities. They can be virtual through contractual relationships, but very often the federal government can regulate things nationally, but our history has been that insolvencies are local. They affect governors and state insurance commissioners, and we really haven't seen yet in any great detail, though it is starting, what should be the state licensure of an ACO, or whether it should be regulated by a health insurance department versus a health licensure like for hospitals or health insurance. And a lot of that raised some of the deja vu for some of the people on the call about what happened many years ago with the HMOs and the PHOs, which is what are they? So this will be out later, and a subscription is required, but the timing of it coming out and having this webinar, I couldn't resist to let people know it's available. We've been getting questions coming through, so I wanted to start with really an opening question that reflects new environment. Gary, if you could just explain what SOCIO is and where it's, I know it's within the Center for Medicare and Medicaid Services, but in addition to explaining SOCIO, can you also explain how it's organized in terms of its interactions with the state?
Sure. I'd be happy to. So when the Affordable Care Act passed, they needed to have an organization that was going to be responsible initially for drafting all the regulations that were going to be needed to implement the various provisions of the law. And so at first, an office was set up underneath in the office of the Secretary of HHS. It was called OCIO, Office of Consumer Information and Insurance Oversight. And then in February of 2011, it became part of CMS and became a center in CMS, so the Center for Consumer Information and Insurance Oversight. And generally speaking, what SOCIO's responsibility is to implement the provisions of the Affordable Care Act that affect the private insurance market. So in the first, I would say, year and a half, what that meant primarily was, well, it set up the pre-existing condition program, PSIP. It drafted the regulations that put in the initial market reforms that went into effect, changing how plans can rescind policies, have to make a showing of fraud or intentional misrepresentation, kids up to age 26 on their parents' policy, limits on annual limits, and whole set of regulations that had to come out. Also stood up the medical loss ratio program and the rate review program, both of which went into effect in 2011. And meanwhile, it was getting busy in figuring out what these exchanges were going to look like. And so it had a significant role in working with states that wanted to operate their own exchanges, and then, of course, in helping to develop all the rules that were going to apply to the federally facilitated exchange. And so there's a whole bunch of regulations and guidance and so forth that had to be put out as far as that's concerned. There's a division within CSIO called the Office of Oversight, and I was the head of that before I became the director. And its role, broadly speaking, is to make sure that the market reforms are being complied with throughout the country. But because insurance has typically and traditionally been a matter for state regulation, not federal regulation, really what CSIO does is primarily in this regard is work with state regulators to assist in making sure that the law is complied with. And in fact, this is identical to the way things were done when HIPAA was passed. So HIPAA was a federal law; it applied across the country, but the statute and the regulations under HIPAA say that states have primary authority to enforce the law unless they decline and they say we're not going to, or unless a determination is made by the federal government that a state is in fact not enforcing the law. And we use that same regulatory mechanism for compliance and enforcement of the provisions of the Affordable Care Act that affect the private insurance market. So states continue to do their traditional regulatory function. They continue to review products. They continue to do market conduct exams. They continue to handle complaints, and they do so under the framework of what the federal law provisions are, except in those few cases, as I mentioned, there are 5 states that decline to do that, in which case the CSIO is responsible for directly enforcing the law in those states. Does that answer your question?
Can you also speak to CSIO's role in the rate review?
Sure. So it's kind of a similar concept. So the statute just said that the Secretary had to establish a process for reviewing unreasonable rate increases. So the first thing we had to do was define what was an unreasonable rate increase. And so we said, well, we're only going to look at rate increases at 10% or above, and then we're going to have certain criteria for what makes them unreasonable. And we really borrowed those largely from existing state law, plus the additional factor of whether the medical loss ratio was not going to be met if the rate increase went into effect. But then we said that as long as states agree to review rates under those criteria and following certain sort of generally accepted practices for what rate review entails, we're going to allow the states to continue to do rate review and to report their conclusions as to whether rate increases are unreasonable or not. And over time, the number of states that have taken on that responsibility has grown. And so in most states now, the states are doing the rate review. There are a few states for which CSIO is doing the rate review itself.
So one of the areas of a question has to do with the re-enrollment. If you could just spend a few more minutes, I realize that the federal regulators had a choice to make, whether to ask everyone to re-enroll every year and take that moment in time during open enrollment to make a conscious decision whether they want to stay in the plan or not, similar to the way employers do, where they send it around during open enrollment period, knowing that premiums are different, the networks are different. It's not always business as usual year to year, versus re-enrollment, where if you have to affirmatively do something to switch, I'm sure that there were a lot of pros and cons of each way, but if you could just speak to, I know there's been a lot of discussion about enrollment versus re-enrollment. If you could just explain again a little bit about what people can expect November 15th forward if they're in the individual and small group market.
So, well, individual market, what's going to happen is that if you do nothing, if you were enrolled in a marketplace plan and you do nothing, and the government the government doesn't have any data that shows that because of your income you're no longer eligible for a subsidy, everything is going to stay the same. You're going to have the same subsidy, and you're going to be kept in the same plan that you chose for 2014. Unless you take affirmative action to go back through the process and submit your information on your income and then go shopping again, that's what's going to happen. You're going to be automatically given the same subsidy, and you're going to be automatically re-enrolled in the same plan that you were in. And obviously you're right. There are trade-offs. The decision was made that we want to keep as many people in coverage as we can, and the easiest way to do that is to leave them where they are. Making sure, and obviously, the information is going to have to go out to people, which is, if you have had a change in income, if you do want to think about changing the plan that you're in for whatever reason, maybe you want to plan with a different deductible. Maybe whatever the reason might be, you're absolutely free to do that. But if you take no action, you're going to stay where you are.
There's also the issue of market share. I know that a lot of the plans that historically were in the individual market or small group decided to not be in the market the first year, and now they're coming in the second year into the public exchanges. Maybe you could just comment, do you think there'll be big swings in the market share?
Well, that's a great question, and actually I meant to, you've reminded me that when I was talking about competition and how well that has, the goal of increasing competition has succeeded, what we are seeing, and the Secretary, I think, just announced within the last week or so, 25% more plans being available, sort of across nationally, in the marketplaces than was true in 2014, and there are some notable examples, United Health Group, being one, where they've been quite clear that they entered a few of the markets in 2014, and now they're entering significantly more markets for 2015, and I think not all of the data or information is out yet on premiums. I think, as we've seen, cost has really been the driver for people's choices, by and large, of marketplace plans. And so if United, it's not surprisingly, not just because of automatic enrollment, but certainly because of automatic re-enrollment, it's a lot easier to hold on to someone than it is to get a new customer, right? Retention rate typically, even without, this is fairly high. So you would expect that new entrants would have to come in and be reasonably aggressive with respect to price if they want to achieve significant market share, make a shift, as you're asking, in terms of where things are now. The additional question, though, is what's going to happen. I mean, there's still a goal of bringing in a lot of people who did not sign up in year one. There's going to have to be a significant effort, marketing effort, both on the part of private plans and also on the part of the marketplaces, state and federal, to reach those people who, for whatever reason, did not sign up in year one. So there is an opportunity for new entrants. They have an equal shot, right, at the people who didn't sign up for a plan in year one along with everybody else.
So with that, I've gone through some of the questions that have come through, and I know people have time commitments. So I wanted to thank Gary very much for taking the time to prepare the presentation, for giving the presentation. One of the things that Gary and I spoke about was how do you balance, the regulatory scheme of consumer protection so it doesn't stifle population health management innovations, and it's a constant balancing. I know that come November and December, many of us are going to see health reform back on the front pages, notwithstanding our foreign affairs right now, and notwithstanding some sporting event. But I'm sure we're going to see health reform back at on the front pages, and we'll have to see whether there'll be regulatory reactions or whether innovations for population health will really come through, because we all know we have to bend this cost curve in order to afford what we need, and we need access to good health benefits, and hopefully we'll be able to balance everything at the same time. With that, I'm going to turn it over to Whitney.
Thank you for joining us. This concludes today's webinar. In approximately 2 to 3 business days following the webinar, Epstein, Becker, Green, and EBG advisors will communicate the availability of the webinar recording and access to the PowerPoint materials. It will include a survey so we can get your feedback for future programming. Thank you.